Good morning. Today, I'll be taking a lecture on the fluoride toxicity. First, the introduction. Fluoride uh, is an ion, the reduced form of fluoride when as an ion and when bonded to the another element. Inorganic fluoride contains compounds are called fluorides. Fluorides known as a halides in a monovalent ions -1 charge. Fluoride never occurs as a free element in nature. Structural and to some extent chemically. The fluoride ions resembles the hydrogen ions. 75 to 90% of the ingested fluoride is absorbed, readily distributed through the body. 99% of the body burden of the fluoride retained in the calcium-rich areas, such as bone and the teeth, where it is incorporated into the crystal lattice. Fluoride is excreted primarily by urine. Like every chemical, there are safe limits for the fluoride ingestion beyond which harmful effects occur. These effects can be classified as acute due to a single ingestion of a large amount of fluoride, chronic due to the long-term ingestion of the small amount. Now, first, we'll talk about the acute toxicity. Ingestion of acute fatal dose of the fluoride is very rare. Hodge and Smith in 1965 conclude that the certain lethal dose of the sodium fluoride for a 70 kg person was 5 to 10 grams when taken orally. This corresponds to a fluoride dose of 32 to 64 mg fluoride per kg. That is, any adult who ingested that much fluoride would be expected to die. With Ford in 1987 and 1990 concluded that probably toxic dose of the fluoride is 5 mg fluoride kg of the body weight. The probability toxic dose was defined as a minimum dose that could cause the toxic signs and the symptoms, including the death, and that should trigger the immediate therapeutic intervention and the hospitalization by the Whitford in 1987. Now, the pathophysiology. Instead, fluoride initially acts locally on the intestinal mucosa. Following ingestion, the GI tract is the earliest and the most commonly affected organ system. Forms hydrofluoride acid in the stomach, which leads to the GI irritation or the corrosive effects. Once absorbed, fluoride binds calcium ions and may lead to hypocalcemia. Fluoride has a direct cytotoxic effects and interferes with a number of enzyme systems, disrupt the oxidative, phosphorylation, and the glycolysis, coagulation, and the neurotransmission by the binding calcium. Fluoride inhibits sodium-potassium ATPase, which may lead to the hypercalcemia by extracellular release of the potassium. Fluoride inhibits acetylcholinesterase, which may be partially responsible for the hypersalivation, vomiting, and the diarrhea, cholinergic sign. Seizures may result from both hypomagnesemia and hypocalcemia. Severe fluoride toxicity will result in the multi-organ failure. Central vasomotor depression as well as the direct cardiotoxicity also may occur. Death usually results from the respiratory paralysis, dysrhythmia, or the cardiac failure. The gastrointestinal signs predominate hypersalivation, nausea, vomiting, diarrhea, abdominal pain, dysphagia, mucosal injury. Electrolyte abnormalities, hypocalcemia, hypomagnesemia, hypercalcemia, hypoglycemia. Now the neurological effects, headache, tremors, muscular spasm, tetanic contractions, hyperactive reflexes, seizures, muscles weaknesses. Cardiovascular widening of the QRS complex, various arrhythmias, shock, cardiac arrest. Now we'll talk about the chronic toxicity. Teeth enamel fluorosis can occur following either an acute or the chronic exposure to the fluoride during the tooth formation. The fluorosed enamel is characterized by retention of the amelogenesis in the early maturation stage and by the formation of a more porous enamel with a subsurface hypomineralization. Both the human and animal studies shows that the transition early maturation stage of the enamel formation is the most susceptible to the effects of the chronic fluoride ingestion at above optimal levels of the fluoride in the drinking water. Now, the fluoride may influence the maturation stage of the ameloblast by the two means. It may reduce the quantity of the proteoneases by interfering with the synthetic or the secretory pathway of the ameloblast. Or it may reduce the quantity of the proteinases by affecting the gene expression or the protein synthesis process. It is given by the Den Basten and the Harifman in 1989. It is very interesting to note that the prevalence and the severity of the fluorosis was high in the children consuming water containing as low as 0.2 mg per fluoride per liter. The author suggested that the location, fluoride in diet, malnutrition, and altitude could be contributing factors for the severity of the dental fluorosis. It's given by the Yoder et al. 1988 and the Ibrahim et al. 1995. Now the bone signs of the skeleton fluorosis appear with a high level of the fluoride intake, 8 to 10 ppm or more in the drinking water for approximately 10 years or more. Now, the severe cases are normally found only in the warm climates where the drinking water contains very high level of the fluoride or where the industrial workers are unnecessarily exposed to the materials such as the cryolite containing large amount of the fluoride. Now, the results of the epidemiological studies have suggested a positive relationship between the water fluoridation and the incidence of the bone fractures. Now, we'll talk about the soft tissue. Chronic health problems of the soft tissues related to the prolonged ingestion of the fluoride in the moderate excess have not been encountered, although numerous studies have been conducted. Now, summarizing the effects of the fluoride, it's a chart, concentration of the fluoride dose, medium, the time interval, and the effects. It may be stated that other than the dental fluorosis, there are no known adverse effects of the ingestion fluoride on a chronic basis at the levels that are associated with the drinking water concentrations of the 4 ppm or less. These levels of the intake would include the fluoride not only in the water, but also in the diet and in fluoride containing dental products.